Hello, this is Sheila Kahneman. I am president of JumpGarden Consulting, and today's talk will be about inpatient acute care unit design. When we are looking to start designing a new patient unit, there are several key questions we need to address. First, we need to look at the level of care that will be provided on the unit, which includes the acuity level, whether there's any type of specialization, such as a cardiology unit or orthopedic unit, and what the staffing ratios are assumed to be. Next, we have to work with our clients to decide the amount of beds per unit and the amount of beds per floor. And then we need to look at the connectivity to the rest of the hospital. What's going to be our horizontal and vertical circulation? How are we going to be moving public, staff, patients, and materials throughout the hospital and to this unit? First, let's look at what the different levels of care are. And this is based on what is the acuity designation of a patient. So for instance, are they most intensive, intermediate, or a medical surgical patient? Or are we looking at developing spaces or rooms that are acuity adaptable? First, let's look at the most intensive area of the hospital, the critical care or intensive care unit. These are the most unstable patients requiring technical or artificial life support, which can include invasive monitoring continuously. Typically, this is about 10 to 20% of beds in a hospital, and these are patients that require a high level of nursing care, typically one nurse per bed or one nurse per 2 beds. The next level down from intensive care is intermediate or step-down care. These are patients that need frequent but non-invasive monitoring or interventions. So they may be monitored, but they don't need the constant supervision. They're more aware of their environment. They're starting to become ambulatory. They're starting to be able to get out of bed. And a more typical nursing ratio here would be 1 nurse per 3 patients. The medical surgical unit is the predominant unit in a hospital. These are typically stable patients. They're usually becoming ambulatory, so they're getting up to use the bathroom. There's more family involvement. Families are talking to the patient. And like I said, these are most of the beds in the hospital. So the nursing ratio here is typically 1 nurse to 4 to 6 patients. Sometimes at nighttime, it'll be 1 nurse to 9 patients. In recent years, we've been studying the idea of acuity adaptability. The reason for this is to keep patients within one room and not being moved as their acuity level changes. We've seen the most success in this in areas where the predictive stay is known. For instance, within a heart hospital during open heart, typically a patient will stay 4 days and will go through several different acuity levels. So if possible, they look to keep them within one room, such as the illustrated room here at Ross Heart Hospital at Ohio State. We're not always able to do this for various reasons, including the different training of staff members for the different acuity levels, but you'll see that for the most part, rooms are designed for the intermediate care level, even for medical surgical patients. We also discussed that we wanted to look at the amount of patient beds per unit and the amount of units per floor. Here are some examples over the last 7 years of bed towers. You can see there's several that are listed that are academic medical centers that tend to have smaller units and also a larger amount of departmental gross square feet per bed. But typically what we'll see is somewhere between 24 to 36 beds per unit, and then the multiples of that per floor. So sometimes you'll see 48 beds, which would be two 24-bed units, 64 beds, 32-bed units twice over. Not much more than that because of the footprint of the units. And units can take various configurations. Many cases, the patient unit or patient tower forms the image of the building, and given space constraints, site constraints, or views out, can take many, many different forms and still follow the same type of clinical philosophy. So a good place to start to understand the space requirements on a patient unit is to look at the Facility Guideline Institute core requirements. The FGI guidelines are in over 40 states. Some states have their own version of this, but almost universally, these are the rooms required on a patient unit. Clinical workstations for nurses, physicians, and other ancillary support people. Storage for clean supplies. Storage for soiled trash and linen before they're removed off the unit. Medication areas, nourishment areas, equipment storage areas, and then staff support areas such as locker rooms or lounges. So as we look at the drivers in patient unit design, one of the key elements is to try to make them as operationally efficient as possible. This is including reducing the travel distance to some of those support rooms that I just mentioned, the need for visibility of staff to patients, looking at the staffing distribution model, computerization model, how are staff going to chart, and then looking at how supplies will be distributed throughout the unit, as well as how then will soiled elements be removed from the unit. So when we're designing a unit, one of the things we'd like to look to is the key support rooms that I mentioned, not be too far from any room. And typically that ideally would be 60 to 75 feet to a room. This has caused some issues because when we used to design units that were semi-private rooms, we could reach more beds within that 60 to 75 feet. So now we're starting ideas of design to make that more operationally efficient. Likewise, visibility into rooms. We can visualize the doors of about 6 rooms from any core workstation, but sometimes this is a problem if we look at same-handed rooms that with the doors separated, we may only be able to visualize up to 3 or 4 rooms at a time. So this has caused the idea of decentralizing workstations throughout the unit. There's been a lot of studies looking at the best staff distribution model for the best clinical outcomes. And typically what we're looking at is neighborhoods of 12 to 16 beds for medical, surgical, or step down, and neighborhoods of 10 to 12 beds for critical care. So we can have nurses that are assigned to those patients and work together with physicians as a team. A good, clear example of this is Eskenazi Wishart Hospital in Indianapolis, the new public hospital that was finished about 2 years ago. Their floor is designed as a 48-bed floor, of which there's 22 beds per wing and designed into 12-bed neighborhoods. This is a fairly high acuity hospital, but all their rooms and units are designed the same, with subtle changes for the critical care to med-surg floors. So you can see that each of the 2 wings has its own set of supply elevators. It also has a center area where there's staff and lockers spaces. And then for each 48-bed floor, we have separate elevators for patient movement, public movement, and then staff movement, as well as support spaces for those elements. As we drill down to each of the 12-bed pods, you'll notice that each 12-bed, which forms somewhat of a neighborhood, has its own collaboration station, as well as equipment, meds, and clean space. And then even the potential then for charting between the rooms. In this case, we see the configuration of a critical care room with a different type of door that opens up more completely, where on their med surg floors, they just have swing doors. So if we're going to be locating those computers for charting, what's the best place for them? Well, there's a certain amount of recording that needs to happen at the patient bedside, including patient vital signs and information straight from the patient. Sometimes caregivers want to move outside of the patient room so not to disrupt the patient and to be able to concentrate more clearly. There's the need for collaborating at a central workstation, and that's more and more of a need the way medicine has been designed today. So you can see we pretty much need to have opportunities at all of the above. And in concert with that is the use now of handheld devices, tablets, and smartphones. So here's an example of charting outside of a patient room. And then now bedside. On the left side, you can see the computers on a stand, so that could move in and out of a room, can be turned towards the patient. On the right side is a patient that's stationary, assigned to the wall, but has the opportunity with articulated arm to turn so it faces the patient as you're charting. And then collaboration stations, which don't need to look like the traditional nurse station. In many cases now we're building them out of modular furniture so it can adapt to new technology and be adjusted for heights. And these don't need to be rectilinear. In the case of Dublin Methodist, a project done a few years ago outside of Columbus, they were designed as perches so people could come up and do their work and easily then go meet with patients or meet as a team. And here are two examples by the architect MBBJ of a concept of bringing the nurse stations along the corridor so they aren't in a core area, but instead reside outside patient rooms to get more visibility and direct access to patients. Next, an important element is the supply distribution strategy. So we have two strategies that need to be involved here. One is inventory control. So the idea of bringing just the amount of inventory of clean supplies to the unit as needed or just in time, but also be controlled so it can be accounted for and charged to patients. Likewise, we also want to see about bringing supplies closer to patients so nurses don't have to go hunt and gather, and then they can be used in immediate proximity. Also important is infection control supplies, which have now become a necessity outside of each of patient rooms. So these are like gloves and masks and other things needed when some patient is infectious. And also we'd be looking at the distribution of pharmaceuticals. Are they being all held in a medication room, or are they decentralized in locked cabinets by patient bedside? So here are three examples of different types of supply distribution strategy. The first is a supply strategy where supplies are centrally located with automatic dispensing. So it's sort of like vending machines that can account for how the supplies are being distributed per patient and charged per patient. So these are called by the manufacturer's names Pyxis or Omnicell, you'll sometimes hear. And these can commonly be located in one or more places on the unit, but are centrally located. The nurse servers outside of patient rooms, like you can see in this example from a hospital in Ohio, can be tucked in fairly discreetly, but can contain supplies that either are not chargeable or need to be near the patient or used quite often, so that way nurses don't have to be running down the hall to find them. And less commonly these days is decentralized at the bedside versus with a cart or a cabinet. This is mainly because these supplies can become or can be considered contaminated when a patient leaves the unit and need to be thrown out. So it's not quite as good for cost savings. It's very important as we look to design any department in the hospital, but especially patient units, that we create a lot of flexibility and adaptability on these units, because as we see over time, patterns of clinical care change, ideas change, and we don't want to have to go in, especially in a unit that's occupied, and renovate. So this is a study that was done by HKS with Texas Tech, looking at what are the most important elements to create flexibility and adaptability. And just a couple that I'll mention is that we don't develop something that's so rigid and module that it can't be changed. For instance, designing a circular unit of 12 beds, and then in the future they want to operate them as 16 beds. So allowing flexibility between different neighborhoods or elements. Having a lot of good sight lines for patient visibility. One of the things we've done in recent years is design curved corridors to minimize the look of a long corridor, and we've actually found that clinicians don't prefer this. They want to be able to see down the hall to get help if needed. And having proximity of support of core elements, having a lot of space that we can use for these different core elements, but allow them, like clean rooms, med rooms, to be flexible so they could be moved around if necessary. So now that we've looked at the patient unit overall, let's drill down and look a little bit more closely at the patient room itself. Regardless of the type of patient room, there are key elements that we need to look at. That includes designing for the best clinical care, rooms that are operationally efficient, that make it easy to care for patients by nurses and physicians. Looking at the research to use environmental elements to support safety and infection control. Creating the best patient and family comfort and experience. And then allowing these rooms to be as adaptable as possible for different types of specialties and different acuity levels. Safety is very important for patients. We don't want to have lawsuits from patients falling, and patients fall the most when they're going to the toilet room. So one of the things we look at is decreasing the distance of the toilet to the patient bed and allowing patients to get to the toilet holding on to different elements like grab bars. Distance from the patient's door, the room door, to the bed, so staff members can access patients quicker. Recent research has looked at reducing the amount of turns that a patient has to make within the toilet room so they don't fall down, and also allowing housekeeping access to toilet rooms so they can clean the rooms, they can mop up spills so people don't slip. The other studies that have been done have been looking at reducing staff errors, creating repetition of key room elements. So as, for instance, staff goes from medication room to medication room on different floors, that everything is located in the same place so they don't make mistakes. And the idea of same-handedness, which has involved a lot of study, looking at, is it important to have the same handed or the same orientation of each room, especially patient rooms, on a floor, and does that decrease errors? And we'll talk a little more about that in a minute. Also very important is infection control. reducing the nosocomial infections. Those are infections acquired within a hospital that cause many unnecessary deaths a year. That includes hand washing, location of lavatories so people see them and remember to wash their hands, hand sanitizers outside of every patient room. Reducing horizontal surfaces would have been shown that they harbor more infection than vertical surfaces in patient rooms. Reducing supply storage in rooms, as we talked about before, since supplies could become contaminated, and frequent removal of trash and linen from patient rooms. Over the past 15 or so years, private patient rooms have become the norm in the US and are beginning to become the norm overseas, although many countries overseas still house their patients in semi-private rooms or in 4 to 6 bed wards. But there's been extensive study about the importance of private patient rooms, including in the US, especially the very big increase in patient and family satisfaction, the privacy issues of HIPAA compliance, the fact that you can talk about private medical information without being overheard by another patient, and studies that have shown that there's heightened infection control when you don't have to be in the room with another patient. So now let's look at the configuration itself of the patient room and the different types of patient room configurations that we can consider. If we looked at what is the best configuration for care, clinical care, we would say that if we could have the best access off the corridor so staff could get to the patient more quickly and have a lot of visibility of the patient, that would be the best care and bring about the safest situation. Likewise, studies have shown that exposure to nature and natural light can shorten patient stay and certainly improve satisfaction of patients and family. So allowing for a nice window and a clear window wall can be very important. Also, having that space for family accommodation, sort of like the sleeper or sitting area, is also important, not only for the family to attend to the patient, but for safety, because it's a whole other set of eyes caring for the patient and attending to the patient's needs. But we have to place the toilet room, and we've got to get the toilet room as close to the patient as possible to reduce the amount of steps and to create a safer situation. So one would think that this would be the logical setup, to have toilet rooms between patient rooms, maybe on the head wall near the patient. And so you would have both the exterior wall free and the corridor wall free. And this is certainly a possibility. However, if you had a unit that's 16 beds and you start designing the unit so these rooms are between each room, every 2 rooms, you can see that it adds about 20 to 24 additional length to the building, which can not only add to travel distance for nurses and other ancillary support people, but also is more costly because of the amount of perimeter you're generating. Still, there's many hospitals that choose to do this, sometimes on smaller units. This is a recent project at Christ Hospital in Cincinnati, where the toilet rooms are between the rooms. They're on the foot wall, so they are distant from the patient to walk to the toilet. However, there's openness to the corridor and to the window wall. One concept is to look at inboard toilets, toilets that are along the corridor side. This worked pretty well when we had the toilets across the room because you could have windows or doors directly in looking at the patient. However, if we want to move the toilet closer to the patient, it'll start blocking the view of the staff and potentially having a throat into the room or a vestibule into the room. Inboard rooms can be good for patients who are more ambulatory because they can swing out of bed with their IV poles that are typically on the nursing side of the room, where nurses come in from the corridor. And housekeeping can get in and clean the rooms easier because they can reach the toilet rooms without crossing the room and the patient. Outboard toilets also were good when they could be across and you could allow the visualization of patients out of the outside window. But when you move the toilet room close to the patient, then it blocks their views. One concept, especially you'll see in higher acuity areas, is looking at substations for nurses so they can sit and view patients, but you can see that this also can narrow the room entry. Here are some examples of that in a med-surg and a critical care setting. So there's a lot of questions about same-handed rooms. They were first instituted with the idea that they would decrease medical errors, but this is very, very hard to prove because of all the different facets of care, including the fact that in many cases there needs to be support on both sides of the patient or on the far side of the patient because they're infirmed. So this has been very hard to prove. However, we have seen that with this design, a strong reduction in sound transmission, and sound being one of the biggest issues negative for a patient experience. And the other thing we've seen is the potential that's developed for more modular construction. So the more we can make these rooms alike, the more they can be repetitive and can maybe even be built off-site. So many hospitals are now looking at toilet room pods being totally constructed off-site and brought in, and that's the same for head walls and also looking at footwall construction. We have the same types of issues we talked about before with same-handed inboard, outboard toilets blocking views. So there's been lots of creative ideas how we can take the same-handed room and offset the toilet to move it out of the way on either the inboard or outboard side so we can gain the same effect of visualization from the corridor and also views of nature and light and air. So here are two examples. The one on the left, Miriam Hospital, is a canted design where the patient is canted so they can look out the window, and it was proved that they did look out the window more when the bed was canted in this direction, and the toilet is offset to allow for a larger access and visibility from the corridor. On the one on the right, the toilet room is on the outboard side canted, with the bed canted towards the corridor, so there's more visualization of the patient by the staff in a higher acuity setting. And here's an interlocked patient room design that I used on 3 different academic tertiary care hospitals where they wanted a lot of clearance around the bed. They wanted a full wall that they could open up for visualization on the corridor side, as well as a discrete family area. But this is allowing the toilet room to be on the same wall as the patient bed, so it's closer to the patient. Another question is access to the patient. If you're going to have a room design that's same-handed, doesn't matter if it's all situated to patient's right or patient's left. Many clinicians are trained to immediately go to patient right side and to access the patient there or hook up IVs on the right side. So some people feel very strongly that rooms should be oriented patient right, and some people don't think it matters. If we're looking to create the maximum amount of acuity flexibility to allow a bed to be used up to critical care level, We need to do things such as create head wall clearances at 13 feet clear, which is a requirement for critical care, have as much visibility into the room as possible, and then to allow clearances to meet the maximum room sizes. I put into the show for your use the examples of the clearance requirements for the FGI guidelines for the different levels of care. For instance, medical surgical, we have to have a minimum of 3 foot clear around the bed and 120 square foot clear in the room. But typically these days we in the US don't design to this absolute minimum standard. Even for med-surg beds, we'll design to the intermediate or step-down care to keep the rooms flexible, which requires a 4 foot clearance around the bed and 150 square foot clear. If we want a room to be able to flex up or down to a critical care standard, we need to have 5 foot clear on the side facing the corridor. That's for nursing care. 5 foot clear at the foot and 1 foot clear at the head. So nominally a 6 foot clearance in the width of the room for the bed, and also then 4 foot clear on the window side towards any other element. And technology is having a huge impact on how we're designing patient units and will continue to have a huge impact in the future. One of the things that's come to the fore is smart room technology for patient rooms. This can include having digital screens for patients that are keyed into RFID badges on staff members, so as they come in the room, patient can see who that person is and what their role is, so they know what questions to ask and also to know whether they are appropriate to be in the room with them for privacy issues. Things like handheld devices where nurses can monitor the monitors and pumps, things like that within the patient room without having to go in and bother the patient. Which includes full equipment integration, and then also different elements that can provide positive distraction for patients. So care networks, images that can be put on the wall, large screen television or computer access, which has been shown to positively affect a patient's experience in the hospital. So in summary, we're designing these units to bring the best of operational ideas, clinical approaches, patient experience, and flexibility and adaptability in the future. If you have any questions, please feel free to reach out to me at my email below, Sheila@JumpGardenLLC.com. Thanks so much for your attendance.